Okay. All right. Well, hey guys, I'm Kevin McConkey, and this is Aorta and Renal Ultrasound for the emergency provider. So, a brief overview of today's lectures. First, we'll talk about some of the normal views that you need to acquire, how to obtain measurements. Next, we'll go over some of the abnormal images that you might find and the associated pathology with them. And then, kind of scattered throughout the lecture, we'll go over different tips and tricks and scanning pearls to help make your life easier when trying to obtain these images. So, first up, we have aorta. So regarding aortic ultrasound evidence for the emergency provider, you'll see in this top box, this was a large systematic review by Rubano et al., who ultimately showed that there was really high sensitivity and specificity for diagnosing AAAs, even for novice ultrasound users in the emergency department, and that would be anything greater than 3 centimeters. This second graph, I thought was just helpful to include with the AAA diameter and its risk of rupture per year. So as you can see, once you get to about 5 is when the percent risk of rupture per year significantly increases. So that's around 5. But a AAA in general is actually anything greater than 1.5 times normal or greater than 3 centimeters infrarenally. I always think it's helpful to kind of have average sizes of aortas or measurements in general. So for women, that's usually around 1.5 centimeters, and men about 1.7 centimeters. That's infrarenal aorta normal. And then 85% of AAAs are located inferior to the renal arteries. And if ruptured, there's about an 85 to 99% mortality, which is why it's obviously important to grab the ultrasound on anyone who's having flank pain, back pain, abdominal pain, especially if they're elderly or vasculopaths or have other kind of cardiac risk factors for AAAs. So going into normal views, first we want to obtain the sagittal view. So here on the left, I included an image of a CTA, which kind of shows the celiac artery here as well as the SMA kind of taking off and going down. You can see right about here is where the bifurcation of the aorta is. And then here is kind of the corresponding ultrasound image on the right with the celiac trunk at the top and the SMA down below. And you obtain this by using the curvilinear probe. You kind of put it in the patient's midline, just inferior to their xiphoid process, and kind of fan up a little bit to get the initial takeoffs. And then you kind of slide down towards their feet to get the whole length of the aorta. And then here is an ultrasound clip showing what you should be getting. So in the very beginning, you'll see the anterior takeoffs, and then you just kind of slide inferiorly while stabilizing your hand to see that there's no saccular aneurysm or like AAA as you kind of fan down. And then a couple of pearls for this particular scan. So it's sometimes hard to compare or figure out if you're looking at the IVC versus the aorta. So the aorta in general has a lot thicker of a muscular wall. So it's more difficult for the ultrasound waves to actually go through the aorta. So the lumen itself will be less hyperechoic or less, it'll be less dark than the IVC. Next thing is that the aorta itself lies more oblique. So the IVC lays more horizontally. So you can kind of see a little bit of difference with that as well. And if you ever have difficulty seeing the anterior takeoffs of the aorta, you can actually do the IVC fan technique, where that's where you take a look at the IVC dumping into the right atrium, and then you slide over to the patient's left. And then once you're on the aorta, you slide down towards the patient's feet to check for a AAA. And then the last tip is both of these pulsate. So the aorta itself pulsates and the IVC is so close that you can't really use that as a marker to tell which one's which, since they'll both kind of move in your image. So to obtain the proximal aorta view, I like to either find the mantle clock sign or the seagull sign. A lot of people who I've scanned with have no idea what a mantle clock is. So it's this clock that you'll see likely above your grandparents' house, above the mantle. And what the clock face represents is the superior mesenteric artery in the transverse section. So up here at the top, you'll see the superior mesenteric artery and then the aorta just deep to that. And then you measure outer wall to outer wall. And then here's kind of some corresponding anatomy labels so you can see what exactly each thing represents. And again, this is used with the curvilinear probe kind of just inferior to the xiphoid process with the probe indicator to the patient's right. And then there's kind of that mantle clock right there. Next up is a seagull sign. So this is also a proximal aorta view. What this represents is the celiac artery kind of taking off from the aorta, and then you'll see the hepatic artery and the splenic artery, which represent kind of the wings of the seagull, and this represents the celiac and transverse. So that's another way that you can accurately measure a proximal view of the aorta. Next up, we have middle. So that's kind of between the xiphoid and the umbilicus, and you just measure outer wall to outer wall. A pearl for this is that oftentimes people can have bowel gas or some adipose tissue that can be in the way, so you can apply a pretty significant amount of pressure with the probe. The patient likely won't feel it, but that'll help displace some of that gas and make the image easier for you to acquire. And then lastly, we have the distal view. So on the left is a clip that I usually like to include right at the bifurcation near the patient's umbilicus. And that can really help you to distinguish, kind of aorta versus IVC. And then here on the right, we just take a still clip from outer wall to outer wall and measure that. And that's usually done at the patient's umbilicus or belly button. And then moving on to pathology. So the reason why we like to do the sagittal view of the aorta is to check for a saccular aneurysm. So here on the left, you can see we're fanning down and there's this really large AAA. And you can see kind of this isoechoic area within the lumen that represents an intramural hematoma. Here on the right is a good measurement from outer wall to outer wall. And you can see right here, I'm not sure, can you guys see my mouse? So here is that isoechoic area with the hematoma, and you measure outer wall to outer wall. And this is around like 4.9 centimeters. And then next up here is abdominal aortic aneurysms. This is mostly what we're looking for. You can see here, I like to usually include kind of the whole length of the AAA, and then I like to do a separate clip of or measurement of the true lumen. I think it's helpful to, in the future, to see if that lumen's changed or if that intramural thrombus or hematoma is enlarging or expanding. And then this image on the right I included just to show how subtle AAAs can be. So this one is 3.15 centimeters, which is just kind of over that little cutoff that we have for a AAA. But the other thing that this image I think illustrates well is that you can see the vertebral body here is roughly the same size as the aorta, and that's always abnormal. Usually the aorta is very small and not the size of a vertebral body. So even before you measure it, you can kind of get a little bit of an inkling that could be what's going on in AAA, just based on the relative sizes between the two. And then here is a very concerning image of a ruptured AAA. So if you ever see this image, you should be on the phone with a vascular surgeon immediately. Oftentimes patients don't make it to the ER when they have a ruptured AAA, but if they do and you're able to ultrasound it, you should see this. Here you'll see a very enlarged aorta with this kind of isoechoic area in the middle that's representing a clot. And then you can see here over on the side the free wall rupture of the AAA and some blood actually pulsating into the abdomen itself. Here's another example of a AAA rupture. This is with color flow being thrown on. So this is a sagittal view of aorta. You can see some of the liver here, aorta transversing down here, a large aneurysm right here, and then you can see the pulsatile flow kind of through the wall of the aorta into the abdomen itself. So it's always good to remember that you can use color flow if you're ever not entirely sure what you're looking at. Next up, we have an aortic dissection. So aortic dissections are actually diagnosed using the normal views that you do for the aorta, the sagittal and the transverse. This would be for a type B dissection. And what you see is this kind of hyperechoic string or flap moving around the lumen. You can see it right here, as well as right here in the transverse. And that just represents kind of the false lumen, and that's for type B dissections. You can actually find type A dissections. This is a little bit trickier and something I felt like I didn't learn about until fellowship, but you can take the cardiac probe, have the indicator facing towards the patient's left, just above their suprasternal notch, and kind of fan down. And what you'll see in a normal view is what we have here on the left. So you'll see the ascending aorta, and then the brachiocephalic artery, the left carotid artery, the left subclavian, and then it dips down into the descending aorta. And normally you should see a lumen that's just completely black or anechoic and nothing kind of in the middle. But here in this second image, you can actually see that same dissection flap here through the ascending aorta. I recommend that you guys do this, especially if you're doing your cardiac exam using the cardiac probe already. Just try focusing on doing that suprasternal notch. Practice makes perfect. So the more of these you do, the possibility that you might see a type A dissection in the future. And then here is an example too of how the aorta can be used for patients who have already had even aortic interventions done by vascular surgery. So this is an endovascular graft that was placed for a AAA. So here on the left, you'll see a large AAA and then kind of this hyperechoic ring in the middle. That is actually the graft that the vascular surgeons put in. So if a patient has abdominal pain and discomfort, has already had a previously intervened on aorta, there can still be a lot of issues, the most concerning being endovascular graft leak. So this is, again, where color flow Doppler is helpful. So you can throw the color flow on there and you'll see that there's a leakage outside of the lumen itself. So this is a vascular emergency that you need to get vascular surgery involved with. And then here's just another example of me liking to get an example of the AAA itself as well as the true lumen. So you'll see here the graft is about 1.6 centimeters. All right, so moving on to renal. First up, we have the renal evidence for ultrasound for the emergency provider. There was a review by Wong et al., which showed that ER physicians in general with pretty high specificity can find moderate to severe hydronephrosis, but a little bit less for just mild hydronephrosis. So you'll see 94% specificity here for moderate and severe, and then only about 75 for more mild cases of hydro. And again, this is for kind of all comers and even novice learners, so not necessarily just ultrasound experts. And they also found that any hydronephrosis was suggestive of a usually larger stone greater than 5 millimeters. However, it's important to note that any stone can technically cause hydronephrosis. Doesn't necessarily matter how big it is. It can, depending on that. So moving on to the normal views. So here's a long axis view of the kidney. So what you'll be doing is using your curvilinear probe, have it kind of in the mid-axillary line, right and left, and then kind of fan completely through the kidney to make sure that you're not skipping any areas. It might miss a little cyst or hydro. And then here we have a short axis view. So this is where you kind of turn the probe indicator about 90 degrees counterclockwise, probe indicator to patient's back. The kidney itself should kind of be circular or sort of oblong looking. And then you want to fan from the superior pole to the inferior pole, making sure that you're not missing any part of the kidney when you're scanning through that. And a little pro for this one, the ribs oftentimes cause shadowing and get in the way, especially in the left kidney. So you can have the patient take a deep breath in. That kind of expands the lungs, pushes the diaphragm and kind of the abdominal organs down out of the way of the ribs. So that's an important thing to kind of remember if you're having difficulties getting this image. And then here's another normal thing that I feel like oftentimes learners get tricked up on, that being the medullary pyramids. So these are normal, kind of these anechoic areas within the kidney themselves. You can see that they're pretty uniform looking, and there's a similar degree of renal parenchyma kind of between the pyramids and then expanding to the capsule itself. This is normal architecture on ultrasound. It doesn't represent a cyst or hydro. This is all normal variants. And then moving on to some pathology. So here is a simple renal cyst. You'll see with simple cysts, these are perfectly circular, thin-walled, anechoic or dark black. There's no septations or any abnormal contours. They're usually found on the periphery of the kidney, but they can be located kind of throughout. Anything greater than 4 centimeters does require follow-up because there is always that risk that it can turn into a malignancy or it can become complex later on in its course. I always think it's good too to take a still image and just measure from kind of like posterior and anterior wall and kind of laterally. And you'll see here this one's 4.2 centimeters, so this patient should follow up. And that is different from complex renal cysts, as these usually have some kind of abnormality that you can see within the cyst itself. So here on the left, you'll see all these kind of hyperechoic septations in there. This middle one has a irregular density within the cyst itself. And then here is a little bit more subtle, but you'll see that the contours and kind of the wall of the cyst is not perfectly circular. Complex cysts always require follow-up with nephrology to have kind of serial monitoring for their diagnostic workup. So if you ever see one of these, it's important to mention it to the patient so that they do get that appropriate follow-up. And then next up, we have a polycystic kidney. So these look like a whole bunch of benign cysts, but the thing that's concerning here is that there's obviously so many of them. This can lead to downstream renal failure. So it's important that patients are aware of this if they're not. This patient was aware. He was actually coming in because he felt a large mass in his abdomen. So you can kind of see it here. And then here's a clip. The measurement of this really large cyst that I found was around 13 centimeters. And you can see it relative size to the kidney here. One of the things that you guys will commonly hear patients say when you're ultrasounding them is, can you see kidney stones in this? The answer is yes. So you'll see this hyperechoic little rock here with a shadowing. It's very similar to gallstones or biliary stones. These are sometimes difficult to find, especially if rib shadows are something that are getting in the way of your scan. They might kind of be camouflaged in there, but you can technically see stones in the kidney. And then moving on to what we usually use the renal ultrasound for in the emergency department, that being hydronephrosis. So normally the renal pelvis is this very hyperechoic or white area within the kidney. It's uniform. You can see the pyramids above there. Hydronephrosis kind of represents that distal obstruction, kind of causes a ballooning up of the kidney. And you'll see a little bit of this black or more hypoechoic region in the renal pelvis that's representing hydronephrosis. Mild hydro can be very difficult to actually see on ultrasound, so it's important that you really investigate it closely. And as we saw in that review earlier in some of the evidence, this is oftentimes what's a little bit more difficult to find and easier missed compared to moderate and severe. So here's an example of moderate hydronephrosis. So you can see here it's just a little bit more distinct. You can see that anechoic region kind of more ballooning up of the kidney, and that compared to severe hydronephrosis. So this is actually a patient that I scanned towards the beginning of my fellowship who's coming in for a completely unrelated complaint. And as I was scanning her kidney, I noticed this. And at first I thought this was just a whole bunch of cysts, but you can see here it's actually hydro. She had a distal outflow obstruction that just affected her right kidney. Her left kidney was preserved, so she never really had issues since the left kidney was functional. And sometimes with severe hydronephrosis, you can see this giant ballooning up of the kidney, and it kind of gives this appearance, which we call the bear claw sign, because it kind of looks like a bear claw. And this is also a pastry bear claw, which are my favorite. And then here's another little pearl that's helpful. So sometimes when you're looking at the kidney, people can have very predominant vasculature, and you can be confused whether or not that's an obstruction or hydro versus blood vessel. So here's another example of how color flow Doppler can be very useful in diagnosing obstruction versus just a normal variant. And this is an example of hydro because you can see that the inside does not lighten up. This is a little obvious, but sometimes it can be subtle or tricky. And then here's an example of hydroureter. So same thing, similar to hydronephrosis, but you'll see that the ureter itself will be dilated. You can actually track it down distally, but sometimes it can be a little bit muffled in patient's bowel gas or other anatomy, but you can see here on the long axis view and then short axis here how it's enlarged. And then a couple other fun things that you can run into while doing renal ultrasounds. This is an example of a bladder diverticulum. So you can kind of see that outpouching of the bladder here in the sagittal view, and here's it in the transverse view. You can also see enlarged prostates or irregular contours to the prostate to have the patient follow up. You can confirm Foley balloon placement. You can see ureteral jets, bladder stones, thickened bladder walls for UTI. So there's a whole host of things outside of hydronephrosis that we can see that you will hopefully experience throughout residency. Any questions that anyone has about either of these? All right, perfect. Well, here are my references. If you guys ever have any questions kind of throughout the rest of the year, don't feel timid to let us know and we'll help you out.